My name's Ellen Sachs. I'm a professor at the University of Southern California Gould School of Law, and I'm also someone who suffers from chronic schizophrenia and has had to manage life in the face of quite a few symptoms. Schizophrenia is a brain disorder, and its hallmark is psychosis or being out of touch with reality. If I can make an analogy, a schizophrenic episode is like a waking nightmare. So with all the bizarre images, impossible things happening, and utter terror. Only with the nightmare, you can sit up in bed, open your eyes, and make it go away. No such luck with schizophrenia. So I've had the delusion that I've killed hundreds of thousands of people with my thoughts, and I've had a hallucination of a man standing with a raised knife. It also involves disorganized and incoherent thinking. One of the things about managing a psychiatric illness is to learn your triggers and either avoid them or cope with them. And for me, change is difficult. I need my routine. Excessive stimulation. People with psychotic illnesses become easily overstimulated. I sort of had mild episodes a couple of times in college where I I remember one day in the middle of the winter, I put a blanket over my arms and started running around campus saying I was flying, things like that. But I officially broke down when I went to Oxford as a Marshall Scholar, my first semester there. And it started out looking a little bit like depression with mild paranoid features, but over time turned into more of a psychotic disorder of schizophrenia. It was actually a terrible prognosis. One doctor said very poor, another doctor said grave. And what that means is that I was expected to live in a board and care, be unable to live independently, and work at menial jobs when my symptoms were quiet. And I think three things really helped me. First, excellent treatment. So I've had 4 to 5 day a week psychoanalytic psychotherapy for decades and continuing. I've been trained. The theory is it's supposed to end, but I'm a lifer. Also excellent psychopharmacology once I admitted the need for medication. Wonderful family and friends, including my beloved husband, Will, who give my life a richness and a meaning and help me negotiate symptoms. Having friends and family in my life is like a second set of eyes. And when I'm having a hard time, I will turn to them, and they're extremely supportive. And then an accommodating workplace. USC not only accommodates but embraces my needs. And it's also extremely stimulating intellectually. And using my mind to tackle difficult problems, puzzles, has been one of my best defenses against my mental illness. And as I like to say, my mind is not only my worst enemy, but also my best friend. So those three things came together to let me defy my grave prognosis and really lead a good and a productive and a happy and fulfilling life. So, I think an important message is if you see in yourself or your loved ones early signs of mental illness, get treatment right away. Treatment helps. You shouldn't have to suffer. Consistent treatment has helped me enormously. There's evidence that the sooner you intervene, the better the outcome. The more people put a human face, the less stigma there'll be. And the less stigma, the more people will seek care and get the treatment that they need. So having a mental illness is not a sentence to a bleak and painful life. You can have a good life. There is hope. Just get into good treatment. Encourage your friends to understand your illness and help you. Find some kind of work or volunteer job or art or whatever that you like to do and gives you satisfaction and gratification. And if you do all of those things and you get good therapy and good medication, you can have a really rich and fulfilling and good life.
My symptoms included loss of appetite, inability to sleep. I guess for a while I was irritable. I would begin to shun people because I knew something was wrong and I didn't want them to know.
Peggy Templeman is 78 years old and has experienced depression throughout her adult life.
It would come and then it would go for maybe over 40 years.
About 2 million older adults in the United States suffer from full-blown depression. Another 5 million suffer from less severe forms of the illness. Depression in later life can be caused by a variety of factors.
The triggers for depression are changes in health, traumatic events, major changes in one's life circumstances, loss of people who are dear to you, loss of the ability to do the kinds of things that you are used to doing and give you pleasure.
The triggers for Peggy's bouts of depression included high levels of stress, an inner ear disease, and losing a valued psychotherapist.
And so I began to get sicker and sicker. My husband had to go to work. No one was at home. I was sick, and so I did not take the medication. And so finally, I did make an attempt to harm myself. I was seeking help.
Peggy did get help, and the combination of talk therapy and medications made a significant difference.
With the medication initially, and with talk therapy, psychotherapy, then I really began to get back on my feet. I had a marvelous psychotherapist who I continue to see periodically now.
Peggy's experience with depression involved a spiritual side, which she says was key to her improvement. She even wrote a book about it.
The medications, all of that, and the talk therapy led to the spirituality, the meditation, the sitting in silence, the communing with the Almighty.
Although depression is treatable, people should realize that it may take time to find the right treatments and for those treatments to work.
Treatments for it typically need to be approached as something that's going to take a considerable period of time in order to have a beneficial effect.
Peggy's journey out of depression was long and difficult, but she is now in recovery. And she has a message for those who may be suffering with this disease.
Talk, tell it to the family, tell it to the friend, tell it to the family doctor. Help is here, help is there.
Got 60 seconds? Take a mental health minute to learn about depression disorders. They cause symptoms that affect how you feel, how you think, and how you handle daily life. Depression should be treated by health professionals. Don't try to handle it alone or treat it with alcohol or illegal drugs. Treatments include psychotherapy or talk therapy, medication, and sometimes brain stimulation therapy. These treatments may also be used in combination with one another. If you think you might have depression, talk to a trusted friend, family member, or healthcare provider. The earlier treatment begins, the more effective it is. Learn more about depression through the NIMH website and take 60 seconds to share this mental health minute to help someone else.
Hello and welcome. My name is Dr. Joshua Gordon. I'm the Director of the National Institute of Mental Health, or NIMH. I'm joined by my colleague, Dr. Jane Pearson, Chief of the Suicide Research Consortium and Program Chief for Suicide Prevention Efforts in NIMH's Division of Services and Intervention Research. We're hosting today's Facebook Live event in recognition of Suicide Prevention Week. During this chat, we're going to discuss some of our most recent research findings in suicide prevention, and as well as discussing treatment approaches, warning signs, and really how anyone can intervene to help save a life. Our Facebook viewers will also have the opportunity to ask questions. So please, if you do have questions, type them into the comments section on our Facebook Live event page. We're going to try to get to as many as possible during the discussion. Before we get started, though, I do want to say to anyone out there who might be having difficulties, who might be thinking about harming themselves or trying to kill themselves, please call the Suicide Prevention Lifeline at 1-800-273-TALK. That's 1-800-273-8255, or visit their website suicidepreventionlifeline.org for help. Okay, well, before we get to questions, we're just going to talk a little bit to introduce you to the kinds of research findings we've been discovering here at NIMH. And to introduce us, I'll ask Jane to tell us about some of our chief goals in that area.
Great. Thanks, Josh. So NIMH has supported suicide prevention research for some time, but we've been accumulating evidence. So I think we're at some points in our science where we can really apply what we've learned. And it's coming at a good time. We have our partners at the National Action Alliance for Suicide Prevention who've set goals of reducing the suicide rate in the US by 20% by the year 2025. So you might hear the 2025 goal advertised by them and having everybody work towards that same goal. And one way we've thought about this more recently is to understand where people have died. When people have died by suicide, what setting had they been in recently? And we've looked at this from a number of ways and different age groups. And one of the things we're finding is that a lot of people go to healthcare before they die. Some talk about suicide, some don't. And it's not that going to healthcare necessarily is a risk factor, but because people go there yearly, typically, that's an opportunity to find them.
So healthcare settings, whether it be primary care doctors or emergency rooms, these are opportunities to identify who might be at risk. And although many people are identified by their healthcare providers as being at risk, what we found through the research is that if you ask everybody,
Right.
whether you're in the emergency room or your primary care doctor, if you ask everybody whether they've been thinking about harming themselves or killing themselves, you identify a lot more people who are at risk. And in fact, our research has shown further that once you can identify them, you can reduce that risk through some pretty straightforward interventions. So the idea of identifying opportunities, identifying individuals at risk, and intervening, that's a mainstay of our research.
Absolutely. And what we're trying to develop now are tools for providers to think about, okay, if somebody is screening positive, how do we talk more about this to understand sort of their level of risk? Like what kind of resources do they need? And also helping them think through a clinical workflow, because we know they're very busy already. So if we're asking them to add this to their list of questions, we want to make sure people get the appropriate care that they need.
So we focused on healthcare providers, emergency rooms, and primary care doctors. We've also got research showing that using electronic medical records, one can also identify people at risk so that we can remind doctors to ask the right questions, as well as looking for effective means of intervening, particularly in children and adolescents who we know the rates of suicide have been increasing dramatically in that younger age group. In fact, we've developed here in our own research centers at the NIMH a screening toolkit specifically designed for healthcare providers to be able to ask children and adolescents about suicide. It's called the ASQ. It's available through our website. That's nimh.nih.gov. And it's an effective tool to identify children and adolescents at risk. So with that introduction, we're going to go ahead and take some questions from the Facebook Live viewing audience. So please go ahead and type the questions into the comments and they'll pop up here. We'll try to get to them as many as possible. One of the questions that really comes up quite often is, and I see it's come up already here, is what are the indications that someone might be about to harm themselves? What are the things that a family member or loved one
Right.
can recognize?
Right.
Can you tell us something about that, Jane?
Sure. So some of these, you could call them warning signs, and they're not always specific to suicide, but they are things that you should start being concerned about and feel comfortable enough to ask if somebody's thinking about harming themselves or taking their own life. And we want to make sure everybody understands that doesn't put an idea in somebody's head. It really can actually be reassuring to that person that you care enough to know what is really happening with them, what they're thinking about. And that gives you the opportunity to say, let's go get some help and I'll go with you. Let's take care of this. So some of those risk factors could be somebody speaking about they feel like they're a burden to the family. You could have an increase in different mental health problems, anxiety, depression, too much sleep, too little sleep. If somebody's talking about wanting to die or death or giving things away, you should take that seriously. And even if they're not imminently suicide, like they don't have an immediate plan, it's really important to get help. And it's actually easier to get help if somebody's not in an acute crisis. So it's actually a better thing if you're suspicious to get help sooner.
A related question from one of our viewers is self-harm an indication of potential suicide? And how does one differentiate between attention-seeking self-harm and serious self-harm? And I think self-harmful behaviors are risk factors for suicide. And I would say, even as a mental health professional, it can be very difficult to differentiate between attention-seeking self-harm and serious self-harm. And I think any self-harmful event should be treated as if it's a suicide attempt, because many of them are. And certainly it should be an indication to help if you notice it in yourself or in a friend, to get help from a mental health professional.
Right. I think we've got research showing that at times people are saying, oh, this is more for relief or it's a habit, but sometimes it is potentially, life-threatening. So people can go back and forth on that. And we do know it's a risk factor in the long run. So I would take it seriously, and it certainly isn't the best coping mechanism. It is a coping mechanism that people describe, but we would prefer seeing other coping mechanisms.
We have another question from a viewer. How do you feel about the collaborative care model to identify more patients in primary care at risk for suicide? So some of you may know the collaborative care model, something that we've been funding research for all sorts of purposes at the interface between primary care, medicine, and psychiatry. It involves what you might think, people working together to care for patients. And we found that it can be helpful in all sorts of settings. And we have an ongoing study to examine the role of collaborative care for suicide prevention. So as a scientist, it's not so much how I feel about it as it is what's the evidence. And I think the evidence is very promising for the collaborative care model to assist in suicide prevention efforts.
I think one thing that's important about it is it's this collaboration, this team. And we know we don't have enough psychiatrists in this country, and it's a great way to extend their expertise. So they could be on the team, they can help people decide when treatment should change. It's a team that also does making sure people are still connected to care. So we all also know those are important factors. And it's also one of the things that we know just in depression screening, that works very well with this model. It means that you can identify people, get them to the right treatment, they do better, they get better faster through this model.
So you said in depression screening, we know that depression and other mental illnesses do raise the risk for suicide. And there's another question, which is suicide genetic, that came in from a viewer? And another way to phrase that is, are there genetic risk factors for suicidal behavior?
Yes, absolutely. But like anything else that has a genetic risk factor, if you know about it, you're aware of it, you can work to manage the risk. So that can be helpful in a healthcare setting for sure. And that could be added to medical record information. So we're actually in the middle of looking at how do we put all those pieces together to understand somebody's risk and then do something about it to mitigate the risk.
Here's a great question that popped up. What resources do we have for teens who are having peer challenges at school and having suicidal thoughts? Are there tip sheets or something for parents to use, or for that matter, for schools to use to try?
It's a great question. And I think youth are much actually more open to talking about suicide. And I think sometimes the adults are catching up with them. And what I would recommend for people joining us today is to check out the Suicide Prevention Resource Center. It's a great place to look at resources for schools, universities, and healthcare, as we were already mentioning. There are toolkits there for parents, for teachers, and this is something that I think will continue to evolve, because I think we'll be improving like health curricula at schools as kids understand more about this, and as we can think about what's effective prevention, so kids don't even get to the point of thinking about suicide.
So that's the Suicide Prevention Research Center and the
Resource
website
Center.
Resource
Yeah.
Center. Thank you. And the website for that is
sprc.org.
sprc.org.
Yep. It's a great resource.
I want to add, actually, while we have that moment, I want to remind people what I said at the beginning of the Facebook Live event, that if you are having trouble and want to reach out for help, a great source for help is the Suicide Prevention Lifeline at 1-800-273-TALK. That's 1-800-273-8255, or suicidepreventionlifeline.org. I also want to mention another web resource now that we're talking about web resources, which is hosted on our own website, www.nimh.nih.gov. Within that, we have a suicide prevention page. The easiest way to get there is by going to our website, nimh.nih.org/suicide prevention. Or if you forget all that, Google NIMH suicide prevention. That works too.
Yep.
So let's take another question. How can professionals engage families in suicide prevention?
So families end up being sort of the therapists at home often if somebody's being treated in an outpatient setting. There's accreditation bodies for hospitals that have recommended that family members be informed, be a part of the team, the treatment team. So if the professionals that you're seeing have not engaged with you yet around this, ask them. It's really a best practice because everybody needs to know what they're going to do. There's also this tool, or I'd say even call it intervention, of safety planning. So you might want to develop ways of, if something's feeling like a crisis is coming on, what can I do? Who do I talk to? What coping skills do I have that I should remember to try to use? And you can have different levels of this. And that's a tool that's very useful for families and individuals to use.
Yeah, in my own practice, seeing patients who had suicidal thoughts, safety planning was a tool that I used a lot. It can be modestly effective, but a key component of safety planning is involving family members and friends. And I would typically bring them into the office and have frank conversations with them and the person suffering, and come up with plans together. And that's been shown to be effective ways. And we have additional research around that topic. For example, looking at caring communications, that is, approaches to increase communication around suicide as an effective therapeutic.
As a way of staying in touch and how are you doing? And some of those communications can be reminding you to use those resources.
Now, we talked about identifying those at risk, and an effective way of identifying is what we call universal screening. That is, asking everyone who comes into a healthcare setting about their suicidal thoughts. And there's a great question pertaining to that. What is the best way to explain to parents that you are screening their young child for suicide and not having them get defensive or concerned? Oh, you're asking my child about
Right.
suicide.
Sure, it's terrifying to a parent to think that their child's thinking about this. So I would suggest looking at that ASQ toolkit, because there's a lot of information there to help both providers and help family members understand why this is the case. And what we found in a lot of screening, or even talking to, if you're administering the screening orally, talking to somebody, if they're not suicidal, they'll say, I'm not. If they are, they will tell you. And so it's really important to get that information out. It doesn't go away if you don't ask about it. It's there. So it's much better to understand what's there. And I think giving parents tools of, here's what we're going to do about this and how to make it a safer place is really important.
Yeah, no, I think it's really important to maintain open channels of communication, like in most areas of life, but particularly in healthcare provider, patient and or parent interactions. And the ASQ toolkit, which is again available through our site, nimh.nih.gov/suicide prevention. It provides not just the questionnaires, but some context to the questionnaires to be able to explain to your patients and to their families.
Right.
The next question, the latest CDC report found that about 54% of people who died by suicide did not have a mental health diagnosis. Therefore, it seems we need to expand beyond our current mental health centric approach. And what are my thoughts on that? So first, the CDC report did come out in the spring and have what to many of us was the surprising result that over half of those who die by suicide do not have a mental health diagnosis at the time of death. And there's two parts to that. One, I think the questioner is completely correct. We do need to expand our approach to suicide prevention beyond mental health care settings. And that's why we've emphasized things like emergency rooms and primary care settings as where you're seeing your general physician as places to identify those at risk. And that's the only way we're going to be able to reach that large chunk of people who are at risk of suicide, but who aren't seeing a mental health care provider. That said, we've long had research into the antecedents, that is the risk factors for suicide. We know that mental illnesses are strong risk factors. And we also know that if you look carefully into the lives of people who've died by suicide, that many more than 54% of them will have evidence of a serious mental illness, probably closer to 90%, which means that most of those people who are succumbing to suicide, they are actually not getting the help they need for a mental illness that we can potentially treat. So that's all the more reason to reach out into these non-mental health settings to try to identify those at risk, is because we probably can help them in lots of different ways.
Right.
Another question, what are some healthy methods to discuss the topic of suicide with someone you fear is at risk, especially if you're afraid of triggering them or of not validating their feelings?
So it's a difficult topic to bring up, absolutely. So you want to start asking them just generally how they are doing, if you can find out more about what's happening in their lives. And you can ask, I'm really concerned about you. Have you thought about taking your life? Because here's what's worrying me about that. So it's all done in a caring and supportive way. The validating part comes, that's sort of like a clinical question, but validating is really trying to understand that person's feelings and understand where they're at, so you can meet them where they're at and try to help them get some professional care.
Yeah, I think that's an excellent point. As we mentioned earlier, the research shows very clearly asking people about suicide does not increase their risk. Nonetheless, even though I know that data, I know it's hard to bring that up right off the bat. And so it is important to talk to someone generally about how they're feeling before asking them as what might seem as a rude or brisk question as, are you thinking of hurting yourself? But the truth of the matter is that those who are not thinking about hurting themselves are not going to be too offended. And those who are thinking about killing themselves, they are the ones who will feel validated when you ask them. They'll say, I haven't wanted to talk about it, but yeah. And they will find that experience to be therapeutic in and of itself. So, and it's not just experience, we have data on that. We have research that shows that the act of asking is a helpful act.
That's right.
Another excellent question is, are there resources for veterans? And the questioner points out that they account for about 14% of suicides in the U.S. according to the Veterans Administration.
Absolutely. So actually the National Suicide Prevention Lifeline that we've been giving out, 1-800-273-8255, has an option for veterans. And more counselors have been added in the past couple of years to provide that support. And anybody who's had military service could certainly call. And the part about switching to the veterans crisis line section of that is they will know the resources available specifically for veterans to help you.
Okay. Another question that came in, what is the youngest age that researchers and or doctors begin to identify those who die by apparent suicide as being victims of suicide versus being the victims of impulsive accidents?
It's a good question. I think we're starting to look at this as we saw the numbers for very young people go up, and I believe medical examiners and coroners are struggling to figure out how to do this, because in general, you'd have to understand developmental psychopathology to figure out, okay, at what point do kids see death as a final step? And those are all really important research questions. We do know that people who die by accidents and suicide are sometimes these overlapping groups, because it represents some reckless behavior, or there's common risk factors to both. Whether that's the case in very young children, we don't know. But we certainly need to understand this better. Either way, there's an injury involved, and maybe we can find the risk factors that are common to both and try to reduce those.
But I think your point is well taken, that regardless of age, it can sometimes be challenging to determine
Yes.
whether an accidental injury or a suicide is at fault.
That's right.
And it is possible that we're undercounting suicides because some of them are classified as accidental injuries, or for that matter, in this day and age, especially accidental overdoses.
Yes.
Do those who are grieving have higher rates of suicidal ideation, that is thinking about suicide? And how can one best determine risk when someone says something like they wish they were with their
Right.
lost beloved?
Right. It's a really important question for people bereaved by suicide, because it's not that unusual to want to be with the person who's now passed on. However, we want to make sure that those people are getting the help they need. So there are interventions that actually NIMH has supported in complicated grief, where we have some effective interventions.
Complicated grief. What do you mean by complicated grief?
So it's natural to go through grief. The symptoms of grief are distinguished often from depression, because this is a reaction that you're going through. When you have a lot of thoughts about wanting to join that person, or you have your own thoughts of suicide because you feel like you can't go on, your life is not what you wanted, that's an important time for intervention. So there are protocols, we have interventions that are helpful.
Right. So we talked about some risk factors, and I think they apply to complicated grief as well. Yes. as other causes of potential suicidal ideation. Those warning signs that we talked about earlier, feeling like a burden, being isolated, but also things like increased anxiety, feeling trapped or in unbearable pain, increase in the use of substances, whether they be illegal drugs or alcohol. And then when people talk about trying to find a way, looking for a way to hurt themselves or kill themselves, increased anger or rage, mood swings, expressions of hopelessness, like you suggest, and then talking about or posting on social media sites about wanting to die. These are all risk factors that one can see. They don't necessarily mean someone's about to harm themselves or try to kill themselves, but they are indications of risk. And then what do you do when you see those indications of risk? Well, the most important thing, as we've mentioned before, what's the most important thing?
So you want to, after you've asked them, we've talked about how to start that conversation, what to do, be with them, keep them safe. You want to keep them away from the means that they might use for suicide.
So if they have guns,
right,
ask them, to take their guns for them, keep them safe.
Medications that could be fatal. If you're in an area where somebody could jump, you want to get them out of that space.
Right. So we call that means restriction, making sure they don't have access to the ways that they can harm themselves. So asking, keeping them safe. What's next?
Help them connect to some help. And actually the lifeline that we've been giving helps you locate services in your area. And you can call them back if you're not able to find some help. And hopefully every state, every county has some way of doing this. The Suicide Prevention Resource Center, again, can actually map out for you in your state where there are state resources too.
Right. So, and just for everyone who may have missed it the first time, the Suicide Prevention Lifeline is 1-800-273-8255. That's 1-800-273-TALK, or their website, suicidepreventionlifeline.org. and our NIMH website, nih.nih.gov/suicide prevention. So I want to thank everyone for joining us today. We've talked about some of the latest research from NIMH pertaining to suicide prevention. We've talked how what we're trying to do is focus on identifying those at risk. We've given you some hints about how you might be able to identify risk in those whom you care about around you, and what to do when people do acknowledge thinking about suicide. And that most important thing to do, which is ask. We'll try to answer as many of your questions as possible that you've written into the comments, in the comments on the Facebook Live site. And please, again, visit our website for more information and for the addresses of other websites we've mentioned along the way, the phone number for the Suicide Prevention Lifeline, and any other information that can be helpful. So thank you again for joining us today.
Thanks.
I grew up in a, average middle-class family with a middle-class neighborhood, and had all the privileges that you would like out of life, but yet I still struggled with depression. Every night I would just get so depressed, and sometimes even start crying for no reason. I even had a sleepover one night, and with my friend there, this was in middle school, and I just felt like I had to start crying. And I don't really know why. So eventually, I talked to my parents and decided to talk to a counselor, and it helped to sort of talk about some of my issues, but it wasn't very gratifying right away. What really worked for me was the support from my family. They were always open. They always wanted to hear how I was doing. They were supportive of whatever I needed. But specifically, there was the engagement in enjoyable activities. For me, it was baseball, sports. That really helped me find my purpose in life, and really helped me just enjoy life a little bit more. And then I went back to the counselors again and tried to find that fit. It was difficult at first. The idea that there's sort of a stigma attached to having a mental health issue or even going to a counselor. I don't want anybody to know where I'm going. I've been there. I actually had done that before. I sort of said, oh, I have a doctor's appointment. But I never really told anybody where I was going. But I feel like now that it's okay. Hey, I'm just going to go talk to the counselor about some things. That's okay to do. What's important for me is that I did seek out help, and I did find a way to maintain my mental health, and I continue to. I'll be okay. Any part of recovery is just being persistent and just understanding when you need to talk to somebody and preventing a more serious issue from happening.